cut, it will only smoothen. That is the specialty of it. So
We
because,
use-
because it's like I said, it's just diamond dust. So the goal of the diamond burr is to basically flatten the surface. So it will never cut. So you can use it even in your pterygium cases. When you've removed a pterygium and you have these strands sticking out, you can use it. You will never see a defect form. You will only see it smoothen the surface, but it will never cut. Yeah.
Thank you. Thank you so much. Actually, we use in our orbital decompression surgeries. That is why I asked.
Yeah, but you will get a little bit of haze post-operatively because there will be a bit of sterile keratitis that you can manage with a steroid. It will get better.
Thank you, sir.
Thank you, ma'am. Yeah.
Thank you. Now I think we'll move to the next topic. Toric marking on slit lamp by Dr. M. Prabhu Shankar. Okay. Yeah, I think he's not here. Now we invite Dr. Thomas George to speak about YAG peripheral iridotomy.
Thank you. Again, the mechanism that we are dealing with when we are thinking of iridotomy is a pupillary block. There is a resistance flow at the pupil, pressure builds up behind the iris balloons up forward, and you use a laser to create a hole in the periphery, and the pressures on both sides of the iris are evened out, and the iris falls back flat. That's the basic idea. So iridotomy would work in what is called the relative pupillary block. That is one of the mechanisms we think of in primary angle closure, occlusio or seclusio, where there's a posterior synechia, there's a ring synechia, or a membrane across the pupil, that's a full closure of the pupil. Inverse pupillary block, this is where we get when we have a small spherical lens, as in Weil-Marchesani, where the pupillary block would happen when you constrict the pupil rather than when you dilate the pupil. And of course, reverse pupillary block, the concept we think about when we think of pigmentary glaucoma, where you got a very floppy iris which would allow for the iris to drape onto the surface of the lens and zonules, and bolus of aqueous comes in front, and the fronts of the iris would have a higher pressure pushing it backwards onto the zonules. So typical pupillary block you would have in mid-dilated position the block. The reverse pupillary block, I already said that, it flops backwards and tends to have a situation like this where the peripheral iris, mid-peripheral iris is bowed back. That's also called the Campbell sign because Campbell described it first. Inverse is this small lens, so only when you constrict do you have pupillary block. Acute closure, fellow eye, narrow angles, occludable angles, pigment dispersion syndrome, occlusio, seclusia, those are the indications. Then in phagomorphic, aqueous misdirection, nanophthalmos, plateau iris, we need to have a PI in place to exclude pupillary block as a mechanism to come to a diagnosis. So this is a situation where we may need to put in a iridotomy to bring in a diagnosis. If you can't see something, you don't do the procedure. Corneal edema, corneal opacity, a flat chamber. If you do a iridotomy, you would injure the cornea, and non-pupillary block synechial closures like NVG, eyes, definitely it would create a bigger problem. First part of any procedure is to get an informed consent and explain the procedure to the patient. Constrict the pupil with pilocarpine at least 3 times, wait for at least half an hour, preferably 1 hour before we go on to the procedure. Seat the patient comfortably at the slit lamp and delivery system. We use a pulse QSIS 1024 nanometer YAG laser. That means it's a burst mode. That means 3 pulses go in each time you press the trigger. Total power of around 10 millijoules. That is, each pulse is only around 3.5 millijoules. Instill a topical anesthetic and use an Abraham's lens. Why do we need the lens? You see the iris magnified, you get a bigger view of the crypt. Increase the cone diameter, cone angle of the laser. Laser energy is concentrated on the iris. It prevents corneal epithelial burns by acting as a heat sink at the air cornea interface. acts as a speculum and minimizes eye movement. This is what we mean by cone angle. If you don't use a lens, this is axially a larger area can have damage, but if you make the lens converge the beam further, you would have a very small area where you can have damage. It prevents collateral damage. So identify the crypt, hit the spot repeatedly till you go across. You're aiming at a 0.2 millimeters, 200 microns hole in the iris. You should visualize the tissue behind. Its transillumination may happen with a thin layer of tissue still intact. So you should visualize the tissue behind. And if the stroma fluffs up, there's nothing you can do. Wait for 2 days and restart again. Repeat the procedure. You can use argon laser as well. Here you got two techniques, the hump technique where you put spots on either sides and make a hump of tissue where you can penetrate, basically stretching the tissue. Both of these, drumhead, you make a ring of argon burns, and if you're using argon, you go for a high energy spot in the middle, but it's always easier to go to the YAG and bust the thin stretched out area in the middle. This is a YouTube video basically, because most of us don't have a laser with a video on it. That's what you're looking for. When you breach the pigment epithelium, a plume of pigment comes into the AC and you see a gush of aqueous coming through, and that is your end point. Then you see if it's big enough and widen the edges at lower power. Complications, most frequent is hyphema. Quite often it is a very minimal hyphema, that doesn't matter. If it's flowing, you press on the lens for about 30 seconds, it should stop. Don't press for more than 30 seconds because you don't want the CRA flow to stop, central retinal artery. So if you need to press again, release and then press again. Injury to the descemex compromises visualization. Either go to a new site or wait for a couple of days for the cornea to clear and go back to the same place and complete the iridotomy. Theoretically, you can injure the capsule which is sitting right behind. If you do manage it, obviously you will get a cataract after that. It's never happened to me, but it's listed there. One needs to check for the intraocular pressure spike after about 30 minutes to 1 hour. It happens quite often, and quite often the IOP spikes can be managed with one dose of Diamox or something like that. Topical steroids have to be there for at least 1 week, at least 4 times a day dosing with predestate suspension. These IOP spikes, I've had 1 or 2 cases where we have had to give mannitol because it can go all the way to 50 sometimes. So that has to be underlined. Post-procedure IOP has to be underlined. And 1 week later, check IOP and of course do a gonoscopy, because not all angles in primary angle closure open up with PI. About 1/4 of them, there is no difference at all. Where we have thought it would open, it will not open in 1/4. But having said that, you can dilate those angles, those eyes also, because you have got rid of your relative pupillary block mechanism. It should make no difference. Thank you.
Thomas, one question. Regarding this iridotomy, usually, as you said, hyphema or bleeding from the site. There's a practical side we are doing like that. You mark the area with a ND532 YAG laser or argon laser. Which area you are going to do a iridotomy? First to do a argon laser or 532 YAG laser there. So the blood vessels, all tissue will be cauterized. Then you do the iridotomy YAG. So the bleeding can be
Yes.
so one practical.
Yes, I agree with you. It would work like a cautery, and most of the hyphemas would be avoided. It is not 100%. That is one. The only thing I have against that is, the moment you burn iris with a thermal laser like 532 or argon, you have plasma aqueous. Blood aqueous barrier breaks down a lot more with these thermal lasers. So I would prefer to just stay with YAG, which doesn't cause that much of uveitis, but the other one causes quite a bit of anti-uveitis.
So just one more thing. See, we have had, sometimes we come across anterior chambers that are very, very shallow, and still we have to go ahead with the PI in those cases. So are there any precautions that we should take in such cases?
Okay. Earlier they used to say you posterior defocus, yes, so that you do not, but the present lasers, the focus is good enough. I do not defocus at all. I would prefer to know where I am hitting. So the,
Actually, in the
you
YAG,
just have to be more careful. If you hit the decimates, call them back next day.
and in the YAG machine, actually now they have a zero focus and a posterior focus. So would it help if we change to that posterior focus and do it in such cases? That's what I was wondering.
I personally feel that I would prefer to know where I'm hitting rather than 250 microns behind what I'm focusing on. That I don't know. So I do not defocus, but this posterior defocus is specifically to prevent corneal injury.
Corneal injuries, yes. So if it IC is very shallow, that's something, the option available on the machine. It's up to you whether you use it or not.